Thank you so much for the opportunity to discuss this. I think this is such a hot topic for us, no pun intended on the title there. Thank you so much to the authors. I mean, congratulations. This is really represents a lot of work, a lot of patient investment. These are 4 prospective clinical trials. So we are so grateful to have the chance to discuss these trials. I hope to do these authors justice for all the hard work that they've done tonight. And what I would like to do instead of critiquing these studies is just to try to interweave them into the story of the current context of how frontline ovarian cancer treatment is changing. Next slide. These are my disclosures. Oh, and I should also say I'm now greeting you from Richmond, Virginia at the Virginia Commonwealth University. Next slide. So immunotherapy obviously has generated much hope and interest in the media and in patients alike. It has a tremendous history within our discipline, and you can forward that. Immunotherapy is so interesting. It has its own month. Next, go forward, and its own society. Next slide. So the checkpoint inhibitors have received multiple FDA indications over the past few years. And you can see this is just one list of those tumors. And these tumors are various in type. So you've got melanoma, solid tumor, you've got hematologic malignancies, you've got immunologically hot tumors like melanoma and the MSI high tumors. And then you've also got cold tumors such as lung cancer, where checkpoint inhibitors are approved in combination with chemotherapy. And this list continues to grow. Next slide. So enter Javelin 100. Again, this is a greatly anticipated study. The rationale for this trial was that chemotherapy would indeed heat up this immunologically cold epithelial ovarian cancer tumor. And Dr. Letterman elegantly explained the design of the study. Next slide. And unfortunately, we did not see any difference in the experimental arm versus the control arm, which in this case was chemotherapy with placebo. So no other maintenance given on this trial, and possibly even somewhat of a decrement, though this trial is not statistically designed to determine that. Next slide. So, were there populations in this trial that did receive benefit? And we looked at this, the Javelin 100 investigators looked at this by biomarker status. So PD-L1 certainly an important biomarker for many of our tumor types, and in the preliminary data for ovarian cancer that led to the design of this study. But unfortunately, no difference was seen between the PD-L1 positive and PD-L1 negative subgroups as presented. Next slide. And the same was shown for CD8 positive TIL status. So unfortunately, the CD8 positive subgroup not showing benefit and potentially driving some of that decrement, and then the CD8 negative group showing no change as well. Next slide. So where do we go from here? I think, Javelin 100 was really the hope of the first immunotherapy trial in our frontline setting. But maybe we were just ahead of ourselves. Maybe we need to think through our approach before rushing into this trial. It seems that ovarian cancer is clearly different from the other tumor types. And so do we use novel biomarkers, develop non-checkpoint approaches, or look at combinations of either immunotherapy-based combos or other drug immunotherapy-based combos? And that's where the work of our other investigators comes in this evening. Next slide. So Dr. Friedman elegantly presented her trial, which I would submit to you is somewhat premature in terms of its clinical endpoints. And given its design and similarities to Javelin 100, I'm sure these investigators are thinking through their approach to move this forward. But interestingly, they had these nice translational endpoints in the study that did show that either this change or maybe this variability in baseline CD8 positive TIL cell expression was could be responsible for detecting this benefit from checkpoint inhibitor. Next slide. And again, she also showed these changes in the tumor microenvironment that did correlate with the response, where inducing this CD8 expression may in fact be evidence that we are causing an inflamed phenotype and heating up this tumor, making it more sensitive to checkpoint inhibition. Next slide. And so Dr. Rocconi presents a novel approach where instead of using this checkpoint inhibition, we're using a novel tumor-specific, patient-specific vaccine against the tumor. Next slide.
Yeah. Can you make sure everyone's off computers?
And this is certainly shown good side effect profile and did not show any of the adverse events that we commonly see with our checkpoint inhibitor. So certainly this is a good approach in terms of its tolerability. Next slide. So this study will need a larger sample size to determine an overall improvement in recurrence-free or overall survival. But interestingly, Dr. Rocconi showed here a difference in or a potential benefit in the BRCA wild-type population, which with the advent of PARP inhibition has risen to be a very important population on which we need potentially more focus. Next slide. And this benefit carried over into the overall survival for that BRCA wild-type group. Next slide. And so perhaps this may have applicability in this homologous recombination proficient or the HRP population. And so this is a summary of data from our frontline trials that have been presented multiple times at this meeting and initially at ESMO in 2019, showing that the magnitude of benefit is less great in this BRCA wild-type homologous recombination proficient subgroup. Next slide. So the one drawback to this is this type of treatment can be an operational challenge, having to harvest tumor with modification of the autologous tumor cells in the laboratory and then re-injection into the patient. In this setting, it does have the benefit of the tumor being harvested at the time of laparotomy or debulking surgery. Next slide. So in terms of combinations, looking at other immune checkpoint combinations, the NRG looked at adding CTLA-4 to PD-1 blockade alone. This is nivolumab versus nivolumab with ipilimumab. This was just recently published in the JCO, and these investigators did notice an improvement in progression-free survival and a slight improvement in overall survival that wasn't statistically significant with the addition of ipilimumab. But I think you could argue that that magnitude of benefit was not great and would not really stand up to the current standards of care. And this was in the recurrent setting. Interestingly, if you look at at the forest plot that is at the bottom here, you can see that the clear cell type might have derived some benefit from that combination. And so as the clear cell types have been excluded from our PARP trials, that is certainly a population of interest. Next slide. And so here we bring in Dr. Hardesty's study, Ovario, where niraparib and bevacizumab combination did show activity. And in this study, they looked at the HRD breakdown and did show differential activity favoring the HRD subgroups. Next slide. And this study also had a microenvironment sort of hypothesis that the chronic hypoxia and the tumor could upregulate HRD And much like turning an immunologically cold tumor hot could turn an HRP tumor into an HRD tumor. And so I think that this study might be seemingly not fitting into this picture, but if you look at the landscape for our trials moving forward, next slide, you can see that the immunotherapies, the PARP inhibitors, and bevacizumab all are playing somewhat of a role in the current ongoing clinical trials. And so I've summarized these for you here, and these will be in your handout to which you can reference, but I just want to draw your attention to the inclusion criteria where we are expanding these frontline trials to include patients with any BRCA status, with any histology. We have several combinations of PARP plus or minus checkpoint inhibitor plus or minus bevacizumab, and the control arms of these trials are all different. I think with the data that we've seen now at this meeting, it will be really hard to justify a placebo control arm moving forward. And in that context, the bar has really risen in the past year for which a new novel therapy has to compete. And so if you look back at Javelin 100 and consider that in the context of our recent frontline PARP trials, then it showed no benefit over placebo. Imagine what it would look like compared to active comparator. And so I think moving forward, these are the considerations that we will have to think about when looking at our frontline trials. And so the next slide, feeling dejected, is that the worst thing we can do is quit. And if you know me, you know that this statement from Jimmy Valvano since 1993, when I saw him give this speech at the SGO Awards, has gotten me through many failed tests, many failed experiments, failed surgeries, failed trials, and has just a testament to our specialty that we can't stop studying this just because we've had one negative clinical trial. The answers are out there, and the worst thing that we could do is quit. So thank you for your attention.